Please excuse me, ladies and gentlemen. Unfortunately, I got a flu earlier in the week, so please excuse my voice. Nonetheless, here goes nothing. There is a tale so magical about transforming, healing, and resilience. This tale has captured the human mind for centuries and has continued to do so and has become the epitome of hope. The tale is about none other than the mystical bird, the phoenix. The phoenix is a bird that reigns the earth on its own. In other words, this bird is only allowed, it's the only bird on earth at a time. Eventually, it knew that it would get old one day. It knew that nothing, not even itself, would last forever. But the phoenix did not fear death. No. Instead, it welcomed it. So, when it knew that its time had come, it flew to the highest mountaintop, and then it built itself a nest. And after building itself this nest, it looked into the sun, and the phoenix started to burn. Yes, the phoenix quite literally set itself on fire as soon as it had known that its time had come. Now, to somebody who was just passing by or watching, it would have looked like pure destruction, when in reality, it was transformation. As you looked deeper and deeper into the flames, you would see a small shape growing brighter and brighter, bigger and bigger, until eventually a new phoenix was reborn. I would like to liken the story of the phoenix to healthcare systems within Africa. The phoenix did not accept defeat. It saw its challenges, its difficulties, and had known that eventually, at some point in time, it would have to die, or it would have to succumb to its difficulties, but it did not allow that to stop it. Just like the phoenix, we are allowed to rise within our circumstances as well, especially as a healthcare system. We face a multitude of challenges, such as, for example, 93% of the population within sub-Saharan Africa does not have access to safe, timely, and efficient surgery. In Ethiopia, for example, an additional 24.4% of patients have cancelled surgeries simply due to the fact that they are unfit to go under anesthesia and so forth. Now, bear with me, ladies and gentlemen. We are getting to somewhere here. So, you may ask, why is this information vital to you? What exactly is it about this information that can take us places? As I've said earlier, Africa can rise. Africa is capable of overcoming all of these circumstances, just like the phoenix did. Learning to fail forward means we learn to adapt and acknowledge the fact that we can use our difficulties and our experiences in the past to be able to use it as a stepping stone instead of rather using it as failure and letting it end us. So, now, this is relevant within Namibia because 41% of the population has been diagnosed with hypertension, while another 6 to 7% have diabetes. Now, in this case, can you imagine how many people or how many of these patients have these parameters controlled? It turns out that a lot of these patients do not have these parameters controlled, which can lead to a multitude of negative consequences if they are to undergo surgery. A surgery on a patient with high blood pressure, or even worse, a blood glucose that is too high or too low, simply has too many risks to take. In order to bring this case study to life, I would like to look at the story of my mother, for example. So 2 years ago, in 2023, my mother suffered a fall. It was an accident and she had simply fell. But unfortunately, due to this, it necessitated hip replacement surgery, which at the time, doctors advised against because she had underlying comorbidities such as high blood pressure as well as diabetes. As a result, her condition was a bit too complex. It was a bit too risky, as the doctors named it, to continue with the surgery. So they took an alternative route. And this route they call conservative management. What is conservative management? It is the process by which a bone does not heal by surgery, but naturally on its own, simply by stabilizing it in place and limiting a patient's mobility. And this is what exactly was done with my mom. They had placed a cast on her leg, and then they placed the cast on her leg, and then the goal was to keep the bone in place to allow for consolidation. But of course, you can imagine how painful and traumatic it must be to have to heal a bone without surgery naturally on its own. So because she was not able to receive the surgery that she needed, of course, she was immobilized for almost a year. Ladies and gentlemen, we are talking about a year of being bedridden. We are talking about a year of being in pain. We are talking about almost a full year of receiving bed sores. And most importantly, one of the harshest things we've ever had to watch her go through was all of the pain that this procedure came with. Which begs the question, ladies and gentlemen, what do we do with patients, high-risk patients at that, who are supposed to undergo surgery, but unfortunately, due to their comorbidities, they are not able to? Do we send them home and tell them that it is not our story and we have nothing to do with it? Do we tell them that this is none of my concern? Do we allow them to go through conservative management, which, yes, is better in the long run, but if you think about all of the consequences and all of the dire characteristics that it can come with, is it really beneficial to the patient at the end of the day if it drastically reduces their quality of life? Or do we use this as a motive to fail forward? Do we use this as a way in which we can align our motives and our goals to innovation? Instead of telling our patients that, no, we cannot operate you, what other alternatives can we take as a healthcare system to allow our patients recovery despite the fact that they have a multitude of underlying comorbidities? Now, ladies and gentlemen, please do not misunderstand me. Physicians are still within their rights, nonetheless, to advise a patient against surgery, especially if it is within the best interests of the patient. The problem, however, comes in when we advise a patient against a procedure and we do not provide an alternative, a substantial alternative at that. So another problem with the healthcare sector is the lack of specialists, especially in the public sector. Specialists tend to be centralized, either within towns, as in they're not in rural areas, or they are within private care. So what happens to the patients who need specialists and they are in public care? At what point do we take this challenge and use it as fuel to keep us going forward and build a momentum of innovation to be able to change the experiences that other people have had in the past and breed better grounds for us? Ladies and gentlemen, what patients like my mother needed is a group of specialists that could come together and prioritize or stabilize, rather, the vitals of the patient. In this case, she would need people like endocrinologists, who are specialists that deal with hormones. She would need groups of cardiologists, for example, who are specialists that deal with the heart, and even anesthesiologists, together with the specialist that is already dealing with her bone, known as an orthopedic surgeon, to come together and devise a plan that would allow her to go from being a high-risk patient to a patient who is eligible and can undergo operations with minimal risks and minimal complications at the end of the day. Thus, I would like to introduce a potential idea, maybe a way in which we could use this leverage and pain and turn it into a purpose, in an initiative that I call the Virtual Anesthesia Risk Clinic, aka VARC. So this would be a digital platform that is designed specifically to assess as well as to optimize patients who are high risk and allow them the opportunity of surgery when needed. So, the virtual anesthesia risk clinic, first of all, how does it work? What exactly are we getting at when we talk about VARC? To be very important and to be very particular, I would like to emphasize on the fact that this is not necessarily a business. VARC is more of a strategy that can be implemented along with other existing strategies to be able to allow these patients a chance at health, which is their right at the end of the day. So patients like my mom in this case would be enrolled in this system. Her data, her vitals would be taken, and of course the group of specialists would review it for a period of at least 6 weeks, constantly making plans. These plans would include medications that will be administered, medications that would not be administered, diets that would be followed, diets that would not be followed, and so forth and so forth. It would be a battle to control her parameters as much as possible and bring them as close to as optimal as possible to allow her to undergo the surgery that she needed. This is what I'm talking about when I say we need to be innovative. A closed door doesn't always have to be a closed door. As much as there are times where patients, we really can't do much about it, there are instances and opportunities in which all we need to do is be bold enough to think outside of the box and be brave enough to tackle the unknown and experiment. So, as I said earlier, the specialist would sit down and review the data and create a plan, and the specialist would meet virtually. However, the members of the MDT, also known as the multidisciplinary team, which is the team of other healthcare professional workers such as nurses, doctors, physiotherapists, occupational therapists, and so forth, would receive instructions from the specialists. And they would be the ones who would administer these instructions, and not necessarily the specialists themselves. And I will tell you why shortly. So the MDT would treat the patient as per instructions with hopes that one day, not one day, but eventually, the vitals will be controlled enough to allow them to undergo anesthesia. And if the patient becomes successful enough and the surgery is gone and this patient becomes a go patient, we're more than welcome to operate on the patient. So, what would make VARC peculiar? What is it about this system or this initiative that makes it so unique and so flamboyant in its nature? You would also be tempted to ask, where would all these specialists come from, for example? This is why I love the idea of VARC so much, because we are leveraging what we already have and using it to create maximal impact. It means that we take the limited amount of physicians that Namibia already has and use that amount to reach a point of increased patient outreach. So the fact that it's a virtual interaction actually allows for specialists to be able to interact with more patients. For example, patients that are in rural areas, patients that are in areas where it's difficult to get access to a specialist, and so forth and so forth. As a result, the next point about why this initiative is so peculiar is the bridging gap. We eventually, or essentially, we close the gap between patients who are in rural areas and patients who are within areas where there are specialists available. This is what I mean when I say we are increasing patient outreach. Not only that, but there is effective dissemination of tasks, which means that the specialist gets to deal with many more patients at the end of the day. At the end of the day, it is the specialists that are heavily burdened because they are already so few. So we need to disseminate these tasks in such a way that the responsibilities are shared equally, nonetheless. Last but not least, this system is meant to strengthen systems, as I already said. It's not necessarily a replica, but it's more of an additive, something that we can use to make what's already existing even better. So, as I said earlier, VARC is something that will complement plans that are already in action. For example, we have our NSOAP, which stands for National Surgical, Operative, and Anesthetic Plan. So, as a result, this plan is actually put into action because It is a plethora of rules, regulations that are ongoing in terms of surgery. It indicates or it gives a direction to surgeons, medical doctors, specialists about how exactly we're going to deal with certain patients and why we do so. However, VARC would complement this system because, number one, it reduces the in-person workload and allows for specialists to spend more time with their patients, or specifically high-risk patients, which according to the triage are the priority. Secondly, it promotes equity, because at the end of the day, health is a right. Health is not something that is only for the rich, or only for the poor, or only for people of what kind of race. It is for everybody, and every single person deserves the right to access healthcare, safe, efficient, as well as practical healthcare. It also supports data and planning. How and why do we say this? When we do the VARC study, we're actually gathering data about the needs of these high-risk patients, and we could use this data to plan and to visualize on exactly where and what we are going to put our investments to when we're allocating the budgets for healthcare to people. Last but not least, I cannot emphasize this enough, but it's in the essence of this plan is in the fact that it has an increased patient outreach by using or leveraging technology to be able to get to a place one day where we as Africans also have access to telemedicine. The battle. So the current battle lies in the fact that there is a lack of innovation, a lack or a fear rather of change. And we need people who are bold enough to be able to stand up and look at these problems, confront them head on, and face them as well. As I said earlier, at what point will Africa reach a point where we also use telemedicine? Will we always be constricted to our traditional ways, or will we learn to modernize our healthcare through initiatives like this one? Is it possible for us to finally reach a point where we are no longer scared of change, we are no longer scared of it, but just like the phoenix, we rise above our circumstances and we take them and use it as fuel, fuel to keep us going, fuel to keep us expanding, fuel that will allow us to be where we want to be one day at a faster rate? At what point will Africa decide, now is the time to rise? At what point will we decide that this is enough? Enough is enough. No more patients having to go through excruciating trials because of the lack of innovation. So, in this case, as I stated earlier, the battle is the fact that there's a lack of innovation. How would systems like VARC, for example, be able to be our swords in this war? How can we use it as a shield against the lack of innovation? So for number one, this would be a rebirth or a renewal, for example, of the healthcare systems within Africa. As I said earlier, we need to modernize the systems that we already have and move with the times as well. We've been left behind way too much. We need to get to a point where we're also accelerating and moving with the momentum of other countries and other continents of the world. And I believe that this system is one of the many that will allow us to do so. Modernized healthcare, especially in telemedicine, allows us to reach an enormous amount of patients within a smaller number of time. It will allow so much more advances in healthcare, so much more advances in people who, in diseases, for example, cardiovascular, strokes, you name it, simply because people who didn't have access to healthcare previously have it now. And secondly, access and equity, which is what I also said earlier. The fact that we're using telemedicine, technology, and leveraging it to the best of our ability, using it as a power, using it as a tool to heal, is something that will bridge the gap between the higher people, or the higher income class, and the lower income social classes. Moving on to the third point. Learning from failure. So work allows us to be able to pick ourselves up from these failures. It allows us to put ourselves in positions where we take our pain and our anguish and we turn it into hope, purpose, joy for the future, etc. As it says on the slides, it creates wisdom by turning experiences into stepping stones. And that is essentially what it means to fail forward. And last but not least, a system like VARC provides hope for the future and a testimony for resilience. An Africa in which we can convert a patient who is high risk and unable to go surgery or unable to undergo surgery to somebody who is eligible for such causes because we were bold enough to think out of the box and to innovate. So, if there's any 3 points that I would want everybody in this room to take home today, it would be number 1, embrace failure and fail, but fail forward. Embrace innovation. Don't be scared of it. Face it head on, the same way the Phoenix was able to face his or her challenges head on as well. Number 2, advocate for equity, and not just equity in healthcare, but equity in all other fields. It does not matter which field you're in. It can be health, it can be law, it can be engineering. We need to reach a point where there is an equal amount of access to resources for all people, despite their economic background, race, etc., etc. And number 3, we ought to prioritize ethical leadership and responsibility. Yes, innovate, but do not innovate at the cost of your patients or your clients. This means that when we are innovating, we need to make sure that we do so without causing harm to patients, which is also what I emphasized on earlier. For example, like my initiative, which is where we reduce or we bring our parameters into a place where they can be controlled and stable enough for surgery, while also minding the fact that patients still could undergo high complications and also considering those parameters before we proceed with the surgery. So, to conclude, we need to stop equating high surgical risks with hopelessness. Just because somebody it's a complicated risk does not mean that it's impossible. We need to break through these boundaries eventually. We need to be able to rise above the challenges, the difficulties, the burdens, the economic lapse, etc., and decide that eventually we need to move forward. Number 2, technology like VARC can turn limitations into innovations, which is what I want everybody in this room to do. A limitation does not have to always be a limitation. A closed door does not always have to be a closed door. I believe that the Phoenix says something to us, or often reminds us of what we tend to forget, that endings are not always just endings. They could be new beginnings in disguise. In fact, they are not could be new beginnings in disguise. They are that. Thus, we take our limitations and turn them into fuel. And lastly, failing forward means rising together. The more we learn how to take our burdens, leverage, and use them as a power, a tool, the more we will rise as Africans. And we won't rise individually, we will rise together, of course. That, ladies and gentlemen, concludes my speech. I would like to thank you all.